Hello, everyone, and welcome to our second module on adrenergic drugs. So let's start by defining the term adrenergic drugs, which basically means a drug that interacts with the sympathetic nervous system, either to amplify that system or to block it. Drugs that amplify the sympathetic nervous system are sometimes called sympathomimetic drugs, and these drugs can either work directly or indirectly. So in another video, I talk about direct adrenergic drugs. These are basically norepinephrine receptor agonists that bind to alpha or beta receptors. In this video, I'll talk about indirect adrenergic drugs that amplify the sympathetic system by blocking the reuptake of norepinephrine. More on this in just a minute. And then also in this video, we'll talk about drugs that block the sympathetic nervous system. These are adrenergic antagonists or blockers. And some of these drugs block alpha receptors, some of them block beta receptors. Okay, so let's start by talking about drugs that function as indirect adrenergic agonists. So these drugs increase adrenergic activity by increasing the effects at alpha and beta receptors, but they don't do this by binding directly to the alpha or beta adrenergic receptors. Instead, what they do is one of two things. One is they sometimes increase the release of norepinephrine. Other times they block the reuptake of norepinephrine. So to understand this, let's look at my little drawing on the slide here. So let's imagine this is a neuron that's capable of releasing norepinephrine. And once it's released, it can bind to adrenergic receptors like alpha or beta receptors. So the way indirect agonists work is some of them promote the release of norepinephrine. This is how ephedrine and amphetamines work, which we'll talk about shortly. The way other drugs that are indirect agonists work is they block these reuptake pumps so that norepinephrine does not get taken back up into the neuron. And this is the way cocaine and also amphetamines work as well. So let's start by talking about amphetamines, which are stimulant drugs. They activate the sympathetic nervous system. You may know that amphetamines are drugs of abuse. That's what the TV show Breaking Bad was all about. There are also amphetamines available by prescription, like these drugs that I've listed here. So amphetamines have two indirect actions that boost sympathetic nervous system activity. One is they inhibit the reuptake of norepinephrine. They also release stored catecholamines like norepinephrine. And so by doing this, they're going to activate the sympathetic nervous system. So they will cause vasoconstriction, the systemic vascular resistance, and the blood pressure will go up. You also see effects on the heart. The heart rate will rise when people take these drugs, and cardiac contractility can also go up. Their main use is as stimulants of the central nervous system, so not so much to stimulate the heart and blood vessels, but instead to stimulate the central nervous system. This can be beneficial in conditions like ADHD, narcolepsy, and also obesity. And I talk about these things in other videos. What I want to focus on here is just the way these drugs work, and that's as indirect activators of the sympathetic nervous system. Ephedrine is another indirect activator of the sympathetic nervous system. The way ephedrine works is it promotes the release of norepinephrine from neurons. It also has some direct alpha and beta agonist effects in addition to this indirect effect here. So because it increases activity of the sympathetic system, it's going to raise the blood pressure and the heart rate. It also crosses the blood-brain barrier, so it can cause central nervous system stimulation, and this can lead to symptoms like insomnia and restlessness. Really, the only place you'll see ephedrine used in the modern era is sometimes for patients who have intraoperative hypotension. So many anesthetic drugs lower the blood pressure, and so during surgery, the anesthesiologist sometimes needs a drug that can boost the blood pressure. Often what they use is phenylephrine, but ephedrine can be used as well. Phenylephrine is usually preferred because it doesn't cross the blood-brain barrier, so when the patient awakens from surgery, they won't have symptoms like restlessness and insomnia and things like that. Ephedrine used to be used as a nasal decongestion, although this is historical. It's been replaced by pseudoephedrine. Pseudoephedrine is a direct alpha agonist that I talk about in other videos. It causes vasoconstriction, so your nose won't be so congested. And pseudoephedrine has much less CNS stimulation, and that's why it's become the preferred agent over ephedrine. Okay, our final indirect agonist drug that we'll talk about is cocaine. So cocaine, you will read in textbooks, enhances monoamine neurotransmitter activity. So what do I mean by this? Well, shown in the slide is the chemical structure of three neurotransmitters, norepinephrine, dopamine, and serotonin. You don't need to know these chemical structures for step one, but I just want to point out to you that all of them have a single NH2 group, and that makes them monoamine neurotransmitters. And so when patients take cocaine, the activity level of these neurotransmitters in the central nervous system will rise. That will happen for norepinephrine, also for dopamine, and also for serotonin. The reason this happens is because cocaine blocks the presynaptic reuptake pumps for all three of these neurotransmitters. And so one of the things this is going to do is cause generalized sympathetic nervous system activation. So patients will see a rise in norepinephrine activity, and this will increase the blood pressure and heart rate. Cocaine also activates the central nervous system, and that's one of the reasons this is a drug of abuse. It makes people feel alert and sometimes agitated and hyper aware. And then you should know that in addition to these effects right here, cocaine has a completely separate mechanism by which it can function as a local anesthetic. This isn't done anymore. This is entirely historical, but cocaine also blocks sodium channels in nerve fibers, so it can be used as a local anesthetic, and that's how it was first discovered 100 years ago, but now we have other that don't carry an abuse potential like cocaine, and that's what's generally used for local anesthesia. So when a person uses cocaine as a drug of abuse, they will develop cocaine intoxication, and this presents clinically as massive alpha and beta receptor stimulation. So patients will come in with hypertension and also tachycardia. Sort of the classic case, at least in terms of a board question for a person with cocaine intoxication, is a younger patient who may have been out at a party, who's agitated and tremulous, they're tachycardic and hypotensive, and they also can develop chest pain. Chest pain and heart disease is a big problem related to cocaine because the drug causes coronary spasm, and it also raises the demand for oxygen by making the patient tachycardic. When a patient presents to the emergency room with cocaine intoxication, the first-line treatment is with benzodiazepines. I talk about these drugs in other videos, but they're sedatives and anxiolytics. They activate GABA receptors in the central nervous system, and basically what benzos do is quiet down the upregulated central nervous system that's caused by cocaine. Importantly, when someone has cocaine intoxication, you want to avoid beta blockers for chest pain and hypertension. Now, we often give beta blockers to patients who have unstable angina and chest pain, but you don't do that in cocaine intoxication. The reason for this is that when a person has cocaine intoxication, their beta-2 receptors in the periphery are being activated, and this is a good thing because those receptors cause vasodilation, and this blunts some of the alpha receptor activating effects of cocaine. So if you were to give a beta blocker, the patient could develop unopposed alpha receptor activity, and this could lead to severe and worsening hypertension and potentially heart failure, cardiac arrest, or even a stroke. And so this is a key teaching point for board exams and also real life, and that is that although we often give beta blockers for patients with chest pain, we don't do that in the setting of cocaine intoxication because we don't want to cause unopposed alpha activity. And so here's a summary slide with a table of the 3 indirect agonists we've discussed: amphetamine, ephedrine, and cocaine. These are their mechanisms by which they ramp up the sympathetic nervous system, and this is a list of some of the potential uses of these drugs. Okay, now we're going to switch gears and talk about drugs that block adrenergic receptors, and we'll start by talking about alpha blockers, which are drugs that, as the name implies, block alpha receptors. And first I'm going to talk about 2 drugs that are non-selective alpha blockers, meaning they block both alpha-1 receptors, which are found in the vascular system, and also alpha-2 receptors, which are central nervous system alpha receptors. The first drug is phenoxybenzamine. This is an irreversible non-selective alpha blocker. It really has one use, and that's in patients with pheochromocytoma, which is a rare tumor of the adrenal glands that produces epinephrine and norepinephrine. And so because there's so much circulating epinephrine and norepinephrine in patients with pheochromocytoma, you need an irreversible alpha blocker to bring down the blood pressure. And I talk about pheochromocytomas in videos in the endocrinology section. The other non-selective alpha blocker is phentolamine, which is a reversible non-selective alpha blocker. This drug is rarely used in the modern era, but it used to be used years ago because it had a rapid onset of action and it could reverse the cheese effect. So what is that? So in the psychiatry section, I talk about older antidepressant drugs called MAOI drugs. These drugs inhibit the enzyme monoamine oxidase, which breaks down neurotransmitters. And so by inhibiting this enzyme, you would get higher levels of serotonin in the central nervous system. And that's why MAO inhibitor drugs could be used for depression. But a problem with these drugs is that monoamine oxidase is also found in the GI tract, and it breaks down a naturally occurring substance found in food called tyramine. Now, there's lots of tyramine in cheese, so if a patient on one of these MAO inhibitor drugs ate a lot of cheese, like from a pizza, they would get lots of circulating tyramine, and tyramine can activate alpha receptors and cause dangerous hypertension. This was called the cheese effect, used to be seen in patients on these very old antidepressants. And so the treatment for the cheese effect, if a patient came in with headache and severe hypertension from an MAO inhibitor drug, was to administer phentolamine. Both of these drugs, however, because they block alpha-1 receptors, they cause peripheral vasodilation, and therefore they lower the blood pressure. So these drugs can cause hypotension. That's why we use them in pheochromocytoma, to bring down the blood pressure. And then because these drugs lower the blood pressure, they will activate the sympathetic nervous system and cause reflex tachycardia. You will get activation of beta-1 receptors in the heart, And so the typical response from a physiologic standpoint to one of these alpha blocking drugs is for the blood pressure to fall and then a reflex increase in the heart rate. So those two drugs on the last slide are rarely used, but what you will commonly see used are selective alpha-1 blockers. These are drugs that go by names like prazosin and these other names listed here. These drugs used to be used for hypertension, but we have better drugs nowadays. And the reason we don't like to use these drugs for hypertension is because they lower the blood pressure, which is good, but they cause reflex tachycardia, which can make the patient feel like their heart is racing, so that's uncomfortable. So we don't use these drugs for hypertension very much anymore, but we do use them for urinary retention in men who have benign prostatic hypertrophy. The reason they're used in this situation is because there are lots of alpha receptors on smooth muscle associated with the bladder. And so when you block these receptors, you get smooth muscle relaxation, especially at the prostate gland and the neck of the bladder, and this improves urine flow. And so this is why alpha blockers are commonly used drugs to treat urinary retention, and I talk about BPH and urinary retention a lot more in videos in the reproductive section. The main drug that's used nowadays is tamsulosin. This is a selective 1A alpha receptor blocker. So it only blocks the receptor, or it mostly only blocks the receptors in the bladder, and it leaves those peripheral receptors that will lead to hypotension alone. And that's why this is one of the most commonly used alpha-1 blockers for BPH nowadays, and that's because it's selective for the type of alpha-1 receptor found in the bladder. And then there's really only one clinically important drug that's an alpha-2 selective blocker. That's mirtazapine, which is an antidepressant. So it blocks alpha-2 receptors on neurons in the central nervous system that release norepinephrine and serotonin, which is also called 5-HT or 5-hydroxytryptamine. And so when you block these alpha-2 receptors on neurons, you will increase levels of norepinephrine and serotonin in the central nervous system, and this can be beneficial in patients who have depression. The main problem with mirtazapine is that it's also an antihistamine drug, and therefore it can cause sedation and weight gain. And so because of this, this drug is most commonly used in patients who have depression and also have insomnia because the sedative effects of mirtazapine will make them sleepy. And then the main adverse effect of this drug is that patients who take it chronically often gain weight. And then there are lots of clinically important beta receptor blocking drugs. I won't go into detail on these drugs in this video because I talk about them in other places, but there are beta-1 selective drugs. There are also non-selective antagonists. There are some drugs that block beta-1, beta-2 receptors and also alpha-1 receptors. And then finally, there are two drugs that are partial agonists. And I talk about all these drugs a lot in the cardiology section in videos on heart failure and hypertension and coronary disease. Okay, now what I'm going to do is talk about drug experiments. So what do I mean by this? So on your medical school exams and also on your board exams, you will see pharmacology questions where they tell you an unknown drug was given to a patient and they describe the heart rate and blood pressure response. And what they want to know is what receptors are being affected by the drug. And so that's what we're going to talk about now, how to figure out these drug experiment type questions. So let's start by talking about the heart rate effects of drugs that activate different adrenergic receptors. So any drug that activates beta-1 receptors, which are found in the heart, that's going to lead to tachycardia. In contrast, any drug that activates beta-2 receptors, which are found in the periphery, that's going to lead to vasodilation. In response to vasodilation and a fall in blood pressure, the sympathetic nervous system will be activated and that will cause a tachycardia. This is called a reflex tachycardia. So the expected response to beta-2 receptor activating drugs is vasodilation and a fall in blood pressure, followed by a reflex response of tachycardia mediated by the sympathetic nervous system. And then drugs that activate alpha-1 receptors, which are found on arterioles, that will cause vasoconstriction, so the blood pressure will go up. And then in response to the blood pressure rising, the sympathetic nervous system will be dialed down. And in this case, therefore, you will get a reflex bradycardia. So the expected response to any drug that's an alpha-1 activator is to cause vasoconstriction and higher blood pressure, followed by a reflex decrease in heart rate. So on that last slide, I described the expected heart rate response to activation of the different receptor types. Now let's talk about the expected blood pressure response when you activate different receptors. Before we can do this, we have to briefly review some important foundational principles. So first of all, the systolic blood pressure is primarily determined by the cardiac output. When your cardiac output goes up, this primarily raises the systolic blood pressure and therefore raises the mean blood pressure overall. In contrast, the primary determinant of the diastolic blood pressure is the peripheral resistance. So any drug that causes vasoconstriction and raises peripheral resistance is going to mostly raise the diastolic blood pressure, and that's going to raise the mean blood pressure overall. So with that in mind, now we can talk about the blood pressure effects of drugs that activate different receptor types. So let's start by talking about any drug that activates beta 1 receptors. That will raise the heart rate and the left ventricular contractility through beta 1 activation in the heart, and this is going to increase the cardiac output. And so as we just discussed on the last slide, this means that the main effect of a beta 1 activating drug is going to be to raise the systolic blood pressure. The mean pressure will also rise, but most of that will be driven by a rise in the systolic pressure. So shown here is a summary of the expected effects of any drug that activates beta 1 receptors. The heart rate goes up, the mean arterial blood pressure goes up, and this is mostly driven by a rise in the systolic blood pressure. So the classic example of a drug that activates beta 1 receptors is dobutamine. Dobutamine activates beta receptors in the heart, it makes the heart rate go up and the cardiac output rise, and that's why this drug is useful in advanced heart failure. Besides activating beta 1 receptors, however, it also does some activation of beta 2 effects. And when you activate beta 2 receptors, you get vasodilation and a fall in blood pressure. So this cancels out some of the rise in blood pressure driven by cardiac output. So this means that the blood pressure effects of dobutamine in clinical practice are often variable. But what you want to know for your board exams is that the activation of beta 1 receptors by dobutamine is going to do all of these things right here, but you're going to offset some of this rise in mean arterial pressure by vasodilation mediated by beta 2 receptor effects. What about the blood pressure effects of a drug that activates beta 2 receptors? So as we just discussed, when you activate beta 2 receptors, you get peripheral vasodilation. And the main effect here is going to be a fall in the diastolic blood pressure because that's determined by the degree of vasodilation and the peripheral resistance. So any drug that activates beta 2 receptors through this mechanism right here is going to have the mean blood pressure fall, mostly driven by a fall in the diastolic blood pressure. When the diastolic pressure and the mean pressure fall, however, you will get a reflex tachycardia mediated by the sympathetic nervous system. So that means that what's shown right here are the expected hemodynamic effects of a drug that activates beta 2 receptors. It will lower the peripheral resistance and the diastolic pressure. That will cause the mean arterial pressure to fall, and then you will get a reflex rise in heart rate. There aren't any drugs that are purely beta 2 receptor agonists, but beta 2 receptor activation is important for understanding isoproterenol, which is a beta 1 beta 2 agonist. It's going to cause the systolic blood pressure to rise through beta 1 effects that raise the cardiac output. However, through beta 2 effects, it's going to cause the diastolic and mean arterial pressure to fall. What this means is you're going to get the systolic pressure going up and the diastolic pressure going down, and therefore the pulse pressure, the difference between these two values, is going to go up. And that's a classic physiologic response to isoproterenol, is a large rise in the pulse pressure. The heart rate is also going to rise on isoproterenol, and this is driven really by beta 1 effects directly in the heart, but also you get some reflex increase in the heart rate mediated through the sympathetic nervous system because you're having some fall in the diastolic pressure. And then finally, let's talk about the blood pressure effects you would see with an alpha 1 activating drug. So alpha 1 receptors are found on peripheral arterioles, and when you activate those receptors, you get vasoconstriction. What this means is the major effect of an alpha 1 activating drug is to raise the diastolic blood pressure, and that overall will raise the mean blood pressure. And then because the mean blood pressure goes up, you will get a response from the sympathetic nervous system. There will be less stimulation to the heart, and so therefore you will get reflex bradycardia. And so these results are summarized right here. A drug that activates alpha 1 receptors is going to raise the diastolic blood pressure predominantly. That will lead to an increase in the mean pressure overall, and you will get a reflex fall in the heart rate. Classic drug to have this type of effect is phenylephrine. It's an alpha agonist drug. Classic example of a drug that creates these physiologic responses shown right here on this slide. And then finally, we'll talk about the blood pressure effects of a drug that activates alpha 2 receptors. So alpha 2 receptors are really peculiar. They're only found in the central nervous system. You find them on the ends of neurons. What happens is neurons in the central nervous system can release norepinephrine, and then that negatively feeds back on alpha 2 receptors. So if you activate these receptors, basically you trick the neuron into thinking that there's too much norepinephrine being released, and so it will shut down its release of norepinephrine. So the way I think of alpha 2 activating drugs is they basically shut down or blunt the sympathetic nervous system overall. So as a result, you get less output of the sympathetic nervous system, and therefore the heart rate goes down and the mean arterial pressure falls. All of this because of just generally less sympathetic output. And so I've summarized these effects right here. These are just the effects of dialing down the sympathetic nervous system overall. The classic examples of drugs that activate alpha 2 receptors are clonidine and methyldopa. Both of these are very old and rarely used drugs for hypertension. The reason they work is because they decrease sympathetic nervous system activity overall, and that leads to these effects right here, which includes a fall in the blood pressure. So I'm going to finish this video by going through two classic pharmacology experiments that involve adrenergic receptors. And the first pharmacology experiment I'll talk about is called epinephrine reversal. So in this experiment, a drug is given to a research subject or an animal called drug A, and this drug raises the heart rate and it raises the mean arterial pressure. But then when you give drug A together with a second drug, drug B, you get the opposite effect in terms of mean arterial pressure. The heart rate still goes up, but instead of the mean arterial pressure rising like shown here, you get a fall in mean arterial pressure. And this phenomena that I've described at the top of this slide is called epinephrine reversal. The idea here is that drug A is epinephrine. It activates beta-1, beta-2, and alpha-1 receptors at appropriate doses, and that leads to a rise in heart rate from beta-1 effects and a rise in mean arterial pressure driven by an increase in cardiac output from beta-1 effects and also vasoconstriction from alpha-1 effects. So this shown right here, drug A, these are the effects of epinephrine. But you can reverse those effects if you give epinephrine together with drug B, which is phenoxybenzamine. That's that irreversible alpha blocker we talked about earlier. Phenoxybenzamine blocks the alpha-1 effects of epinephrine, so you only get the beta-1 and beta-2 effects. This means that the heart rate's going to go up from the beta-1 effects. That's still going to happen just like it did initially, just with drug A, epinephrine. But you're going to get a fall in blood pressure because you have beta-2 effects from epinephrine and no alpha-1 vasoconstricting effects. So when the two drugs are given together, the beta-2 effects dominate, and that's vasodilation, and that leads to a fall in blood pressure. And so this phenomenon is shown right here is called epinephrine reversal. It was an original experiment done when adrenergic receptors were first being described and characterized and understood. And the idea here is that the effects of epinephrine can be reversed in terms of blood pressure by giving epinephrine together with the alpha-1 blocking drug phenoxybenzamine. And then the second classic pharmacology experiment you should be familiar with is called phenylephrine block. So in this experiment, drug A is administered and the mean arterial blood pressure goes up, but the heart rate goes down. However, if you give drug A together with drug B, you get no effect at all on heart rate or mean arterial pressure. Neither of these two variables change. So in this experiment, drug A is phenylephrine, which we talked about earlier. It's an alpha-1 activator, an alpha-1 agonist. So that's going to cause vasoconstriction and raise the mean arterial pressure. And that will cause a reflex response mediated by the sympathetic nervous system that causes the heart rate to fall. So that's what you're seeing over here on the left, the effects of giving phenylephrine alone. If, however, you give phenylephrine together with phenoxybenzamine, which blocks alpha-1 effects, you get what's shown over here, which is no effect whatsoever on either heart rate or blood pressure. And so this experiment described here in this slide is called phenylephrine block, the second of the two classic adrenergic pharmacology experiments you should be familiar with. And that concludes our second video on adrenergic drugs.